I'm Professor Gilles Montalescot. I'm the head of the Department of Cardiology at the Institute of Cardiology at Pitié-Salpêtrière University Hospital in Paris, France. It's a difficult situation for several reasons. The first one is that heart failure, when it occurs the first time, is going to impact the prognosis of myocardial infarction very much, because roughly 1 out of 2 patients will be dead 5 years later. The second point is that we deal with limitations in the treatments, and one of the limitations is blood pressure. We have good drugs to treat heart failure after an acute myocardial infarction, but they tend to lower blood pressure too much, and these patients quite often have low blood pressure, so we are limited by the blood pressure to administer these drugs, and this is one challenge. And the third point, which is, I think, important, is that when you get heart failure after a myocardial infarction, you are exposed also to other complications, in particular arrhythmias, and of course some of these arrhythmias may be ventricular and expose the patient to sudden death. So a difficult situation to manage, absolutely. So firibastat actually is the first in class of these new drugs that we call BAPIs, which means brain aminopeptidase A inhibitors. And it's a new class of drugs because these drugs at the brain level inhibit what we call the brain aminopeptidase A, which is responsible for the transformation of angiotensin II in angiotensin III. And of course, when you do that, you are going to reduce the release of vasopressin, you are going to impact sympathetic nerve activity. So you are going to influence in the right direction 3 different systems: the renin-angiotensin system, the vasopressin system, and the sympathetic system. And this is what we like to do in this type of patients with myocardial infarction and heart failure to prevent further episodes of heart failure and possibly more serious complications. So the Quorum study design is pretty simple to understand. This is a phase 2 study. It's a multi-center, international, randomized, double-blind study, and the control arm is not placebo. The control arm is a group of patients treated with ramipril. So it's an active controlled arm, and this is very important to acknowledge. We compare firibastat versus what is the standard of care for the treatment of this kind of patients. And we have tested 2 doses of firibastat. One is 100 milligrams BID, and the other dose is 500 milligrams BID. And at the time of randomization, we have performed MRI to look at infarct mass and left ventricular function. And we have repeated MRI 3 months later. And the primary objective was to look at the change in LV, left ventricular ejection fraction, over 3 months of treatment. And the idea was to see if firibastat at one of these doses could be superior to ramipril, which is very effective in preventing remodeling of the left ventricle and preventing heart failure in these patients with a first anterior myocardial infarction. So the primary endpoint of the study was a change from baseline to 12 weeks in the left ventricular ejection fraction, as measured by MRI. And what we observed is that actually ejection fraction tended to improve over 3 months in all 3 groups. And there was no difference between the 3 treatments that we had in this study. So And I could say that firibastat performed probably as well as ramipril, a 10 milligram dose of ramipril, but did not perform better on this endpoint. So it's not superior to ramipril, but let's say it's at least as good. We looked at a number of secondary endpoints on these MRIs, and it confirms that in terms of LV dilatation or infarct mass, we observe globally something similar to ramipril. Safety was very good with this drug, and this is very important to acknowledge. And the safety profile in terms of blood pressure was very interesting, because with ramipril, we had a tendency to get low blood pressures more often than with firibastat, and it prevented the patients to reach the optimal dose of ramipril, of 10 milligrams of ramipril, when 80% of patients with firibastat reached the optimal dose of firibastat. So, and that was done double blind again. So it's very reliable. So the hemodynamic profile was quite good with firibastat. We were concerned by possible skin allergic reactions, but actually we had no difference between ramipril and firibastat. Roughly same number of patients with this kind of complications. And we had one angioedema in the ramipril group. This is a well-known serious adverse event we had known with firibastat, and firibastat has not been recognized as a drug causing this kind of serious side effect. So safety was quite interesting in this trial to provide results in terms of efficacy similar to what we had with ramipril. But again, this is a phase 2 study, not a phase 3 study, where we expect to see a benefit maybe in more serious cases. It's too early to say what will be the clinical impact of firibastat, but the expectation for phase 3 is to go against ramipril in more serious clinical situations, maybe have patients at a higher risk of heart failure, and see if firibastat can compete with ramipril and eventually beat ramipril, because tolerance may be better. The optimal dose may be reached more often with firibastat than with ramipril. And hopefully, we may prevent heart failure better than what we do these days with ramipril. So we need to do that before saying that firibastat is a drug for the future.